Let's talk about some interesting articular lesions in the hip area. Remember, when we examine the hip, first of course the history, you have the standard questions, what's your problem, when, where, how can you influence it? Yeah? One little trick, if you would have doubts, is it a hip problem or is it a referred pain from the lumbar spine? Ask your patient what happens when he or she is coughing. If you get pain on coughing, then you have a very nice lumbar dural symptom. Okay? What's the capsular pattern in the hip? According to Cyriax, lateral rotation, adduction, okay. And then medial rotation and abduction more limited than flexion, and flexion more limited than extension. You notice the question mark. There are several research papers questioning that. And yeah, everything is evolution, of course. I talk more about research, of course, during our live seminars we teach worldwide. But during the years, we came to the conclusion that yes, indeed, we have to rethink that. We have to adapt that a little bit. And we're going to make it more simple. What is the key factor in a capsular pattern? Medial rotation, more limited than flexion. Medial rotation is the first movement which is limited when the patient has a certain degree of arthrosis. So he's going to be the top. Okay, we did hip flexion, hip rotations. Don't use too much force. Yeah. Passive abduction. Yeah. When, for instance, the patient has lateral pain, you squeeze in possibly one or more bursae. Yeah. Or with adduction, you put traction on iliotibial tract. Yeah. Resisted flexion, resisted extension, resisted abduction, adduction, passive extension, bilateral medial rotation. So that's a super test to detect beginning arthrosis, because then visually you immediately see the difference between left and right, and you can also check the end feel. Yeah, one side is going to be a little bit harder than the other side. And then resisted rotations, flexion and extension. So, as usual, I refer to the separate film on hip examination. Have a closer look to that. One extra test, flexion and adduction. This is the major positive test if the patient has a psoas bursitis. Yeah. But about bursitis we have a separate film. Okay, let's imagine there is a capsular pattern, so we think of arthrosis and some other options. Yeah. If the arthrosis is not too advanced, what do I mean by that? If it's not too much limitation of movement with a bony hard end feel, if that would be the case, forget it, hip replacement. So if it's not too severe, at the beginning you can try to do some capsular stretch treatment. Capsular stretch in flexion direction, in extension direction, and in medial rotation direction. Like in the shoulder, capsular stretch is not a pleasure treatment. No pain, no gain. Yeah? Okay. And combine it with mobilization, combine it with exercise. Also here we can find an internal derangement, arthrosis and loose body. So if the loose body is a cartilage fragment, of course you don't see it on X-ray. If you find those things, oh, look at those loose bodies, that's horror. Yeah, of course this should be removed from the joint. But I'm more interested in the loose bodies you don't see, but the loose bodies you hear. Yeah? The history of internal derangement, they have irregular twinges. Twinges where? In the groin, anterior, giving way. Sometimes they lose control, yeah? And perhaps a little bit further radiation in that direction. Yeah? Well, what's the clinical image of an internal derangement? Well, you're going to have a non-capsular pattern. Yeah? Possibly flexion more limited, not anymore the hard end feel of the arthrosis, and lateral rotation, which is negative in the capsular pattern, becomes positive. We have to be honest, sometimes you only hear the loose body, and at the time when the patient presents himself to you, yeah, okay, at this moment I don't have any problem. Yeah. You have the story, but you don't have the image. So that's, that's possible. So again, we're going to manipulate. And again, it's a combination of traction and rotation. Yeah? It looks quite terrible, but don't worry. It is not terrible, and it's certainly not painful for the patient. We have two different options. You rotate in lateral rotation or you rotate in medial rotation. We have a second manipulation technique, but we don't use this one that frequent for the simple reason that the first technique I showed you is mostly so efficient. But okay, watch the films on the techniques a little bit later. Yeah? For instance, if the patient would have osteoporosis, this kind of technique is contraindicated. Yeah? There could also be a loose body in a non-arthrotic joint, but this is not so frequent. Yeah? Okay, the manipulation stays the same, but we have to make a differential diagnosis with a labrum problem, specifically in young adults when there was a certain trauma. And labrum problems in the hip, they seem to be quite different, quite frequent. Yeah? And what do they describe? Pain, locking, catching, instability, giving way, stiffness. That's more or less the same story as an internal derangement. So now I have a little problem. Is this connected with an innocent internal derangement? Or is it connected with a labrum problem? Well, there are some tests in literature. In several films I already told you that in the orthopedic profession there's a kind of overconsumption of tests. Well, we have the same problem over here. That looks nice in theory, but the problem is they are all irrelevant. Yeah? They don't have a good validity, except for one test. The impingement test seems to have a better validity. So we're talking about this test, some flexion, some adduction, some medial rotation, and then provoke quite intensively. Okay. So if this test would be positive, then perhaps it's a good idea to refer the patient for medical imaging, okay, to really confirm the diagnosis. So let's have fun with this manipulation technique.
The patient's pelvis is stabilized by a strap. The therapist stands on the end of the couch, grasps the patient's ankle and holds his limb in about 80 degrees straight leg raise. With a grip that avoids too much movement in the foot, he uses his body weight for applying traction. He maintains this traction while gradually stepping off the couch backwards. In the meantime, during the flight phase, he performs 3 full rotations, medial or lateral rotation. Grip for medial rotation. The therapist faces medially. His distal hand grasps the lateral malleolus, the proximal hand supports and stabilizes the grip. Grip for lateral rotation. The therapist faces laterally. His distal hand grasps the medial malleolus, the proximal hand supports and stabilizes the grip. The patient's pelvis is stabilized by a strap. For a left hip, the maneuver is as follows. The therapist puts his right foot on the couch. By means of an abduction movement, his thigh is put under the patient's knee. Now, the patient's knee is bent, and the therapist half plantiflexes his foot. He leans sideways to increase the traction component, maintains the knee flexion while reaching the end of rotation. The manipulation consists of a high-velocity, low-amplitude jerk towards rotation, combined with the second half of plantiflexion at his foot. Grip for medial rotation. One hand on the outer part of the knee and one hand medially proximal from the foot. Grip for lateral rotation. One hand on the inner part of the knee and one hand laterally proximal from the foot. Half lying on the couch, the legs slightly spread. Two marks are identified: the anterior superior spine of the ilium and the greater trochanter. A perpendicular line is drawn from the anterior superior spine, a horizontal line 5 cm below the tip of the greater trochanter. The needle is inserted at an angle of 45 degrees at the crosshairs in an upper direction, which is well lateral of the femoral nerve and vessels. One will feel the resistance of the thick capsule of the joint. Once this is traversed, the needle will strike bone close to the neck of the femur, or possibly at its junction with the femoral head. Here, the intra-articular injection is given.